All right. Welcome everyone who's joining. People are joining sort of slowly. I just want to give a few minutes to let everyone get in and then we'll get started. I still see that number rising, so I'll give it like just a few more minutes. All right. Well, we'll go ahead and get started. I think it finally has leveled off. Good evening, everyone. For those who are joining from, well, still afternoon technically, those joining from Eastern United States. I suppose good morning for those who are joining from the Southern Hemisphere down in Australia. Welcome to the Johns Hopkins Cochlear Center for Hearing and Public Health 2023-2024 seminar series. Today, we do have a few slides to go through, I think first, right, some logistics slides, and then I'll introduce our speaker in a few minutes. Just in general, as we're going through, please use the Q&A feature for questions. Questions are sent to only panelists and will be asked on your behalf at the end. So we'll have someone moderating the whole time. The seminar is being recorded. If you're having any technical difficulties during the seminar, please email jhcochlearcenter@jhu.edu, and we'll put that in the chat just in case. Admittedly, if you're having technical difficulties getting on, this is a useless statement for you. Closed captioning is provided by Zoom, and CART services are available through Zoom at a specific link that we will put in the chat. Go forward one slide. Just a note about upcoming seminars. Seminars are generally the fourth Thursday of the month from 12 p.m. to 1 p.m. Eastern time. We did do a different time today just to accommodate those, the time differences in schedule. We do them on Zoom or at Johns Hopkins at West 2030 Page Hall. February speaker is Heather Whitson, MD, MHS from Duke University. And our March speaker is our own former trainee, Danielle Powell, now at the University of Maryland. And then Friday, April 19th, just save the date. That is our research day. Rasima Leroy, MD from Ireland at Trinity College Dublin School of Medicine will be our featured speaker. And then we will have several other smaller talks as well as featured student presentations. We can move the slide forward one more. So today, I'd like to introduce our speaker, Dr. Brent Edwards, the director of the National Acoustics Laboratories in Australia. NAL, National Acoustic Laboratories, is an Australian federal government hearing loss research center, and Dr. Edwards leads the research innovation initiatives that focus on transforming hearing healthcare there. For over 20 years, he's headed research at major hearing aid companies, including GN Resound and Starkey, and at Silicon Valley startups. He's had a nice body of work where he's been able to sort of move back and forth and influence our industry. He uses innovative technologies, clinical tools that are now used worldwide from all of these different companies and experiences. Dr. Edwards is a fellow of the Acoustical Society of America, a fellow and current president of ICRA, an adjunct professor at Macquarie University and at University of Queensland. So extremely accomplished. And today he will be speaking to us about innovation and transformation in hearing healthcare. And with that, I will turn the floor over to you, Dr. Edwards.
All right, thank you. And let me just share my screen for you. Share. All right. So thanks so much for the invitation. I was thinking this morning, it's been a long time since I last spoke at Johns Hopkins. That was back when I was visiting Eric Young and Murray Sachs, and at the time presented on psychoacoustics and auditory neuroscience as it relates to hearing loss. So this will be quite a different talk, which probably reflects the change, the transformation of my career and interests. So, the National Acoustic Laboratories were here in Australia. We're a federal government lab, kind of like some of the NIH labs in Bethesda. We've got about 50 research scientists total, and we do a variety of different research, all sort of focused on how to impact hearing healthcare in some way. So we evaluate new technology. We get to see a lot of cutting edge things coming through with our clinical trials. We advise government quite a bit on their hearing healthcare program. Recently, we have advised them on how to better measure patient outcomes from the program, how to redefine the eligibility for hearing healthcare, and that's in part based on what I'm going to be talking about today. And we're currently in the process of redefining minimum requirements for technology to be listed on their program. So, and we do longitudinal studies. We have an 18-year study to follow people who were born with hearing loss to understand treatment on their lives as throughout their lives, and a variety of work. So what you're going to see here is just a slice of the research that we do that is focused on understanding how hearing healthcare is transforming. So, I've been in this field for quite a while now, close to 30 years. And I have to say, most of it has not changed at all. So hearing healthcare, typically someone who might look like the two people here will show up at a hearing clinic or a hospital. Standard battery of audiological diagnostics would be run on them. And then based on the results, they'd be described to the patient. And then if they were deemed eligible for some treatment, typically a hearing aid would be recommended. And if agreed to, be fit. And the only real individualization of choices would be, well, which hearing aid will we put on you? And that's about it. But what we've seen over the past 5 years or so is really dramatic transformation in hearing healthcare that's changing every aspect of how we think about hearing loss and how we think about hearing loss treatment, whether it's new technology being developed, whether it's new ways of providing hearing services to patients, or the channel through which these are delivered. So I've spent a lot of my career talking about hearing healthcare and innovation particularly, and I've been struck during this transformation that quite often people aren't quite understanding how something new and novel fits into the ecosystem of hearing healthcare. So I worked a couple of years ago with Elaine Saunders, who is the founder of what was probably the first direct-to-consumer hearing services organization down in Australia, where over a decade ago they developed basically an internet-based approach to delivering hearing aids and self-fit, and is now sort of a blended model. So we work together to develop this framework of how to think about innovation in hearing healthcare and to really split it up into different channels of where innovation is happening and different spectra of where innovation can fit into the scheme. So you have technology, services, and the channel, as I said, and you have approaches that are very clinical, very medical in their approach, but we're also seeing approaches that are now very consumer focused. And so traditionally, for the past 50 years, almost everything was very clinical. The hearing aids, the technology were medical devices. The services were provided by a degreed audiologist or otologist, ENT. And the channel was a hospital or a hearing clinic. But what we're seeing, again, over the past 5 years or so, is a shift in each of these areas and how hearing healthcare is being delivered. So take teleaudiology, for example, which is probably one of the first innovations that our field has seen. That has really shifted the services more to the consumer side, where audiologists can be involved in the hearing healthcare service provision, but there's a lot of do-it-yourself as well with apps where some of the adjustments and the problem solving could be done by the person in their home. And of course, the channel for the provision of teleaudiology is this combination of the audiologist in a professional location, but the patient in their home or office or anywhere really they want to be. So we looked a while ago on the effectiveness of teleaudiology, specifically because during COVID, down here in Australia, a lot of SAN, which funds most hearing healthcare in Australia, allowed for reimbursement for teleology services just during the time of COVID. So we wanted to develop evidence that to try to convince government to continue reimbursement basically forever for teleaudiology based on measuring patient outcomes. So we took the opportunity that some of our clinics, we are a part of an organization called Hearing Australia. We have close to 200 hearing clinics across the country. We have about 500 audiologists and a couple 100,000 patients that we see every year. So during this time, our clinics were open, but we are also providing teleaudiology services. So it was a unique opportunity for us to measure patient outcomes with those two different delivery methods. We look specifically at follow-up appointments after someone had been fit with the hearing aid, but typically when you see them again to make adjustments and understand how they're doing. And we applied some standard validated outcome measures. What I'm showing to you here is the Glasgow hearing aid benefit profile and the five different subscales in that survey. And what you're seeing is the perceived patient benefit in each of those subscales for either the in-person, in-clinic visit in blue on the left of each of those five, or in gray, the patient outcome from the remote hearing services. And what you can see on this scale as a population, and this was several hundred in each of these groups, there was no differences on average between them. And so ultimately, the government down here decided to make permanent their reimbursement for this appointment category. And, we think in part it was demonstrating that there wasn't a disservice, there wasn't poor services being provided to the patient because of this. So other innovations that we're seeing, of course, is over-the-counter hearing aids, in large part due to Frank Lin and other folks at Johns Hopkins. And if we think about where that sits within this framework, it's still a medical device, so it's still a technology that fits in that clinical side, but the services don't have to be provided by an audiologist. And I think the typical OTC model is the audiologist is not involved in any services that get provided, are self-directed by the consumer. And the channel, of course, is very consumer focused. We've seen traditional hearing aid companies like Sonova acquire or partner with traditional consumer companies like Sennheiser in order to deliver these products. And of course, the channel, this is a photo I took last year in Costco, where hearing aids are being sold right beside Fitbits and other consumer electronics. So we have at NAL looked at this self-fitting, what we called self-fitting back at the time, and the challenges that existed in this model. So back in 2017, we ran an experiment with a device that had been designed for self-fitting to see how successful people were. And I won't get into the results, but the bottom line is only about a third met the criteria of success for self-fitting. And based on our research, we identified there are a lot of barriers and a lot of issues that need to be solved in order to make someone successful with a direct-to-consumer or self-fitting hearing aid. Now, it's not that these are barriers that can't be overcome, but it's not a simple matter of putting a traditional hearing aids in someone's hands and saying, okay, it's your job now, take over. There are a lot of issues that the person is facing and that need to be thought through by the organization or company that is providing these devices for self-fit. So the point is this, as with all innovation, often there are unique challenges with adoption for this technology. And this may be what we're seeing now, but it's certainly not surprising and certainly not something that can't be overcome either. But, I also want to sort of challenge, if we consider this framework, one of the things I like about the framework is you can consider these levers that you shift back and forth, and you can develop your own model for hearing healthcare provision. And so while the traditional, everyone thinks of over-the-counter with this, where the technology is clinical, services and channels are consumer, you can start to shift the dials a bit and come up with a different model. So what we are seeing, for example, is people who are getting OTC hearing aids through a consumer channel are ending up going to audiologists to get help with the device. So the service is now sort of this mixture of do-it-yourself consumer and clinical. But you can also change these levers in a different way, have the service be complete consumer and have the channel be clinical. There's nothing that requires OTC to be in the consumer channel. It's just that perhaps that's where the most obvious point for it is. But I know a very successful otologist with a hearing aid practice who for a few years has been offering do-it-yourself hearing aids in his practice, preset hearing aids that can't be programmed, that are relatively cheap, and is for people who can't afford or don't want a traditional hearing aid that requires multiple visits and so on. So for those patients that come to his practice, within his practice, he's offering essentially direct-to-consumer hearing aids, even though he hasn't been calling it that for a while. So I guess part of my point here, as we think of innovation technology, there's an obvious sort of framework in which it falls into technology services and channel, but they can be adjusted. You can think of different approaches to develop novel ways of providing hearing services. So if we think about solutions that are out there to help with hearing loss, but aren't hearing aids, so technology that are alternatives to hearing aids, there are quite a few on the market now. There's hearables, there are apps on phones, there's programs on PCs, there's accessories that you can get in consumer electronics stores or ordering online. We decided to try to understand how useful are these, and how similar are these to the traditional delivery of hearing aids. So we looked at AirPods in particular because of some innovation that was happening, and I think also just because of the attention that Apple gets whenever they do something. And I know during the discussion of OTC, there was a lot of speculation that if someone like Apple were to get involved in providing hearing aid solutions, it would revolutionize our field. And that is sort of what they've done over the past few years. So initially, what Apple released a few years ago is something called transparency mode, where they took their AirPods and they added a microphone on the outside. So instead of streaming audio while you're wearing these occluding devices that's keeping you from hearing things around you, they added a feature where you can turn on microphones and then pass the audio through transparently to the auditory system. And to do that, this is some measurements we did in our lab showing how much insertion gain the AirPods are doing in transparency mode. And it's what you'd expect, basically a flat 0 dB insertion gain. So almost as if you weren't wearing the AirPods, almost as if they weren't occluding you, because you would get 20 dB or more attenuation of environmental sounds without this feature. So it's not a leap of sort of logic to say, well, if you have a microphone out there, it's picking out sounds around you and you're applying enough amplification to get 0 dB insertion gain, why not add a little bit more gain and help people with hearing loss? And that is basically exactly what they did with headphone audio. So there's two ways that this technology works in the AirPods. One is they have some preset amplification that appears to have been designed for mild hearing loss, and I'll show you some data in a second. But you can select on your phone, on your iPhone, slight, moderate, or strong settings for the amplification that you get. And you can select the quality, I think basically the bandwidth and the slope of the gain using this balanced tone vocal range or brightness selection. But you can also actually enter your audiogram, which is interesting. So it's a consumer electronics product. It's not a medical device, but you can enter an audiogram, program it to your diagnosed hearing loss, and it provides amplification in the exact same way a hearing aid would. Yet it's not a medical device, so that's quite interesting. So we decided to say, well, how similar are these to hearing aids? So this is the insertion gain that you get for that setting of vocal range for 3 different levels of input, 50, 65, and 80 dB SPL. And you can see the gain is primarily above 1,000 hertz, and you get up to close to 20 dB of gain for soft level sounds. And the fact that the gain falls as level goes up means it's in compression, which is what hearing aids typically do to mimic the nonlinearity of a healthy auditory system. So we then programmed some audiograms into the AirPods to see how much gain would they give for different levels of hearing loss. I'm going to show you the result here for this mild to moderate sloping hearing loss, going from 20 to 50 dB hearing loss. And this is what we measured. The solid line is the insertion gain of the AirPods. The dashed line is the prescription. Most hearing aids around the world use a prescription that we developed at NAL over a decade ago that takes an audiogram and calculates how much gain as a function of level at each frequency the hearing aid should provide. So think of it this way. The dashed line is what a traditional hearing aid would provide for that audiogram. The solid line is what the AirPods are doing. So you see for the orange line, 65 dB SPL, which is the level of conversational speech, the AirPods are very, very close to what a traditional hearing aid would give for that level and to what our prescription recommends. For low levels of sound, we see that the solid line is providing less gain than a traditional hearing aid would. And at high levels of sound, AirPods are giving more gain than a traditional hearing aid would. Now, we've actually had some conversations with the people who developed this at Apple and asked them their logic behind this, and they have told us that they did not take our fitting prescription at all into account into the design of this, and this is simply based on preference. But from my perspective, typically more compression you have, the more it takes time for someone to get used to it. So it's not surprising to me. It's a little bit more linear in its in its action, which is what this represents. So I'm going to talk about AirPods a little bit more from a patient perspective and patient benefit. But getting back to non-hearing aid technology here, again, we see everything is really on the right-hand side of the consumer, but it doesn't have to be. There could be non-hearing aid technologies that are medical in their approach. There could be clinical services associated with them, and they could be delivered through a clinical channel. So, this is something that we are considering and looking at in our 200 clinics across Australia, for example, for people who, for whatever reason, don't want hearing aids or maybe aren't a candidate for hearing aids. What other solutions can we provide for them that could still help with the hearing difficulty that they have? So all of these products out here, we're trying to understand for whom can these benefit, and when would a clinician make a recommendation of these technologies, and what would be the expectations they would set for the benefit that patients would get from these. So again, focusing, we've looked at several technologies, but focusing on the AirPods, we ended up developing a training for audiologists in order to understand actually how to use AirPods as a hearing aid alternative. Because it's actually, surprisingly for Apple, it's non-intuitive. It's a little bit difficult and challenging to figure out how to turn AirPods into hearing aids, but you can. And that's something that we're starting to investigate as a clinical solution that audiologists can recommend for a specific type of patient. So I think, again, even though technology, a lot of innovation has a certain approach, quite often consumer approach, there's nothing that keeps it from having more of a clinical focus, or even allowing for services, audiological and hearing healthcare professional services being applied to them. And we've looked at a lot of other technologies that I won't get into in this talk from that perspective. So finally, I'll mention AI, just because AI is sort of a hot topic everywhere. It's quite a hot topic in hearing healthcare. We've been doing a lot on AI over the past 5 years at NAL, and over the past year, we've been focusing more on generative AI from a hearing healthcare perspective. I think part of what gets me on these topics is talking to audiologists, and there's always a fear factor of whatever is new in our field is going to obsolete the field of audiology and replace them. My response, forever has been, it's just another tool. It's just another service for people who need help, and people will always need the help of a hearing care professional. So, but AI is another one that's causing some angst and people to wonder, what does this mean for healthcare? So a pretty smart audiologist in the US decided to ask ChatGPT, what is the role of audiology in the world of AI? And by the way, where does AI fit on this spectrum? I don't know, but it can probably fit everywhere. You could probably put these dials anywhere on the left or the right, and AI will have a role in that way, whether it's very clinically and medically focused or very consumer focused in this approach. But what does ChatGPT think about AI and audiology? So the audiologist published this conversation with ChatGPT. I'll just show you the answer to one question of how AI might improve patient outcomes. And basically, you know, as a tool, which is not surprising, this is how AI is being integrated in other areas of healthcare, is to help the healthcare professional in diagnostics and in personalizing treatment strategies based on, obviously, assessment of big data and looking at how to match the characteristics of the patient with previous treatments that have worked and been effective. It's also can be quite useful in monitoring how patients do over time. And this is something that we've developed at NAL as well, particularly for children. But, you know, again, it's all about being able to assess data in an automatic way where humans simply can't track their patients every single day and look at every single data point that gets produced. Again, analyzing data to make predictions of future patient needs. And then also, obviously, automating some tasks that basically, you know, aren't a good use of the hearing healthcare professionals' time so that they can focus on things that really leverage their skill. You know, for me, I think the audiogram is an obvious one here. Why we need a highly trained audiologist professional to run an audiogram is still baffles me. But I think there's a lot of ways where AI can offload the services that audiologists provide. So again, when thinking about innovation in hearing healthcare, it's happening in a lot of different ways. And there's in my mind, a mix and match model here. And some of these lever positions haven't been invented yet. So I think there's a ton of opportunity if you look at what's happening now and then just turn the dial here, move a lever to the side and find a new opportunity. That's kind of how I'm thinking about how transformation is going to continue to happen in our field. Now, I want to get back to, you know, our typical patient that comes in asking about hearing help, because again, we've tended to treat everyone the same. And, you know, I started thinking about this because, you know, about unique populations here, because in our clinics, I discovered a while ago, about 1/3 of the people who come in to our clinics asking for hearing help, when we measure their audiogram, they have what we would call normal hearing. So they have a pure tone average less than 25 dB. And so what do we do for these people? Our audiologists go, congratulations, you have normal hearing. You don't need my help. Come back in 5 years and we'll test your hearing again and see how you're doing. But it begs the question, why are these people coming to our clinic asking about hearing help in the first place? So that got me thinking about, you know, different subpopulations within people who have, you know, hearing dysfunction of some sort, and thinking about unmet needs. So I tried to understand the differences between a measured hearing loss and a perceived hearing loss, and also what the size of the populations are for this group in the US. So this is sort of a chart of a figure of all the people who have hearing dysfunction of some sort. The left column are people who actually have no measurable hearing loss according to the audiogram. And the right column are people who do meet the traditional definition of having a hearing loss. The top row are people who don't recognize that they have any hearing difficulty at all. If you ask them, they don't think their hearing has any effect on their lives. The bottom row are people who will say, if you ask them, do you have hearing problems, or is hearing causing a difficulty in your life? They will say yes. So you can kind of segment people into these different categories. And then down here, you have people who have a hearing loss. They know they have hearing difficulty, and you can split those between those who have hearing aids and those who don't. So when we talk about, you know, who's a consumer for a hearing aid, who's a consumer for hearing healthcare, we tend to think about this group here, the people with a measurable hearing loss. because that's how we define, the need for what we have to offer. But, there's a very large group here. I estimated to be 25 million in the US, but it's some large number. And again, 1/3 of the patients we see in our clinics come in and they fall into this group and they have hearing difficulty. It's affecting their lives. And we as a profession are not doing anything for them. We're dismissing, their need generally. We're not trying to give them a solution, and in part because we don't know what to do. No one has really investigated what is an appropriate solution for someone who falls into this. Thanks to Charlie Lieberman and others, hidden hearing loss is starting to get talked about, and that is a possible group within here. But I think this is more than just people with hidden hearing loss. These are people who, for whatever reason, are struggling with hearing and is causing difficulty in their lives. So that became a big focus for research in our area. And I started asking audiologists at various conferences, given all these different audiograms, which is the lowest number that if they showed up in your practice, you would recommend a hearing aid. So I've asked this of thousands of audiologists now. And basically I ask them, I'll say, raise your hand if you'd recommend a hearing aid for someone with audiogram number 1. No one raises their hand. Then I'd ask about number 2, and maybe 1% of the audience would raise their hand for number 2. Once you get to number 3, where you now have a pure tone average of a little bit more than 25 dB HL, then audiologists start to become comfortable. I've even met audiologists, though, who will still say, you know what, that's still pretty mild. I'm not sure I'm comfortable recommending a hearing aid for them. So, there is this ingrained treatment is associated with the level of your hearing loss according to the audiogram. So that begs the question, again, why are people coming to our clinic? Who's coming to our clinic who don't have a hearing loss? And so we decided to look at this. We interviewed about 100 people who came to our clinic who ended up getting a normal audiogram and told, congratulations, come back later. And, in terms of the demographics, it's not that these are people in their 30s who are concerned about, temporary threshold shifts or something. These are the aging population, just like a traditional, hearing aid wearer who has hearing loss. Now, when we asked them a variety of questions about why they're there, when we asked them what level of hearing loss they thought they had, this really shocked us that half the people we asked thought they had at least that they had a moderate hearing loss, and almost a third thought they had a severe hearing loss. Yet they had normal hearing they had no hearing loss as defined by the audiogram. We asked why they were there, what's the primary cause for them to seek help. The number one cause was they perceived that their hearing problems was somehow limiting their life in some way. So a classic definition of a healthcare issue. So this raised a couple of questions that we've addressed at NAL over the past several years. One, if you have this, what I'll call minimal hearing loss, do they need the help of a hearing healthcare professional? And if the answer to that is yes, how do you treat them? If they don't have a hearing loss, what do you do to help them? So let's consider what is defined as a healthcare, disability. So the World Health Organization talks about, body functions, daily activities, and how you participate as defining your well-being. But they also say these can be affected by the environment around you and also other personal factors you have. Now, if you think about the audiogram, that's just that first bullet point, bodily function and structure. Everything else is not really officially a part of that decision into whether treat someone and whether someone needs a hearing solution or not. This, landmark report on hearing a couple of years ago by, again, World Health Organization called out specifically, this is a quote from the report, that hearing thresholds should not be used as the sole determinant of hearing disability and sole determinant of whether someone needs a hearing aid or a cochlear implant. Now, this is something that we've known in our field for a long time, that the audiogram is not a good indicator of need and benefit from hearing devices. In fact, this task force a couple of years ago shocked a lot of people in the field. They make recommendations on, all aspects of preventative healthcare. And I think most people in the healthcare field would say you need to screen for hearing loss once you reach the age of 50, because then the prevalence of hearing loss starts to increase. Their recommendations in 2021 was to not have a screening for adults. And the reason was that a screening, hearing screening, is basically a simplified audiogram. And they concluded that the audiogram was not a good way of identifying whether someone would benefit from a hearing aid. And so once again, sort of a pretty damning condemnment of audiograms as the primary tool for determining whether someone needs hearing healthcare or not. Again, we've kind of known this for a long time. Here's a study from back in the 80s where 20% of people who reported that they had a hearing loss actually had what we'd call normal normal audiograms. And on the flip side, in another epidemiological study, almost half of the people with a measurable hearing loss said that they had good hearing. So there's this disconnect between the measured level of hearing loss and the amount of disability that hearing ability is causing in someone's life. So it also, raises the question, what is the audiogram good for? Why do we use it in the first place? Well, it does have its purpose. One, it tells us, at what level people can't hear sound. And this is quite useful for determining if you give someone a hearing aid, how much gain they should get. And it's also related to how well someone understands speech, but only very loosely. Here's data showing the relationship between speech scores on the y-axis and level of hearing loss on the x-axis. And you see there is a correlation. But if you pick any level of hearing loss, like let's say 47 here, there's a wide range of speech ability. So while there's a correlation on any individual, it's not really a good indicator of how they're functioning and how their hearing ability is affecting their lives. So we decided, so if we want to try to understand whether we should help someone who has normal hearing according to the audiogram, what other diagnostic tool is there that our clinicians can use in order to, one, validate that the person has a disability that needs help, in order to help guide, policymakers on who they should be providing hearing health care to. So we looked at two different groups of people. You see the audiograms of the two different groups here. Both, we tried to match them as identically as possible. One group of people said that they had their hearing ability was affecting their lives. The other group of people said, hearing wasn't a problem for them. So we ran a battery of tests over 20, I think 26 or so, to try to see, is anything a predictor of which group that person fell in. In other words, a tool that a clinician can use to say, yes, you seem to have an abnormal auditory function in some way. Psychoacoustic tests, physiological tests, self-assessments, behavioral tests. And after doing all of this, we only found one measure that was very highly predictive, with 96% correct, I think, of predicting who fell in what group, and that was the HHIE questionnaire, which is almost self-fulfilling because it's a questionnaire about how hearing is affecting their lives, which we were trying to predict in the first place. But not even a speech and noise test was able to tell us which group a person fell into. But we were heartened by the fact that the HHIE questionnaire was correlated with other measures of auditory damage, such as OAEs, middle ear muscle reflex, ABRs, envelope following responses. But those physiological measures were not powerful enough on an individual basis to be able to make a treatment recommendation. So the science, I think, supports HHIE as a measure, but on an individual, it wasn't good. So this is what we are now doing in all of our clinics. We are applying this questionnaire as a part of the intake in order to understand the need of the person. So here's what the short version is. And it's basically the kind of questions that an audiologist would ask a patient about, how hearing is affecting their lives. Number 8, does a hearing problem cause you difficulty with TV or radio? Number 10, does a hearing problem cause you difficulty when in a restaurant? And Larry Humes, a few years ago, when thinking about OTC, actually came up with this survey as a recommendation for how to identify whether someone needs an OTC hearing aid, presumably because they wouldn't have access to an audiogram. And so he published this data showing the relationship between the audiogram, the pure tone average, and the HHIE score. Now, typically what we would do, so this is the pure tone average on this axis going from 0 to 70, HHIE score going from 0 to 40, and the size of the peak is the number of people in this population that fell into both. Typically, we draw a line at 25 and say, if you're to the left of that, you need hearing help. If you're to the right of it, you don't. So Larry's recommendation is you draw the line this way on the HHIE score. If your score is worse than 10, you need hearing help. If it's better than 10, you don't. Now, if you look at the combination of both, someone who scores poorly on both, there's a lot of people there and there's a correlation between the scores. So if you do one, you're going to capture people who would be identified on the other. But there's a big number of people here who have a measurable hearing loss, but according to the HHIE, don't have any hearing difficulty. Now, I've talked with audiologists in our clinics, about 40% of people who have a hearing loss and get a hearing aid recommended to them decline the hearing aid. And our audiologists will go, well, they're in denial. They need a hearing aid, but they just don't want to accept that they do, or they're not ready yet. Well, it could be they actually don't have a problem. The hearing is not affecting their lives, even though they have a hearing loss of some sort. And so we shouldn't be wasting our time if someone has a very good score, according to HHIE, trying to convince them they need hearing help, because guess what? They actually don't. They don't have a need for a solution. But look at this group here. There's a large number of people who are scoring really poorly on this, whose hearing is really affecting their lives, but they have normal audiograms. And so we're saying, you don't have a problem, goodbye, and come back later and we'll see you again. So this is the group that I think are not being serviced well by hearing healthcare providers or by researchers or by manufacturers of solutions. So we also looked at 13,000 or so of the people who have come to our clinics who ended up having normal audiograms and looked at their HHIE scores, and about half of them score poorer than 10. In other words, they have a significant need. Hearing is affecting their lives in some way. So again, very large population of people here that we're dismissing out of hand because the audiogram doesn't characterize them as someone who has a hearing need. So hopefully at this point you believe that the audiogram isn't the perfect indicator of whether someone needs hearing help, and that there is a need for people who fall in this demographic for some sort of solution. And so then, of course, the question is, what is a solution for someone who has normal hearing and doesn't need amplification from a hearing aid? Well, we decided to just go straight for the jugular on this, said, tell you what, we're going to fit a hearing aid on these people anyways and see whether it gives them benefit. So we recruited 30 people who have normal audiograms but have self-assessed speech and noise difficulty, and created two groups, an experimental group who got a high-end hearing aid that was fit with a certain amount of gain and noise reduction, directional microphones, and beamforming. The control group got the same hearing aids, but we programmed them with 0 dB insertion gain and none of the speech and noise features. We tested both groups in our laboratory. We had both groups wear the hearing aids for 6 weeks out in the real world. We used a lot of real world measures of benefit, a lot of surveys to understand the differences between these groups. So I'm just going to show you a very small set of the data that we got. Here are the audiograms of the of who we recruited, by the way. So again, no audiologist in their right mind would fit someone like this with a hearing aid. In fact, they would say it's unethical to do so. So when we asked them questions such as, are you convinced that obtaining hearing aids was in your best interest on a scale from 1 to 5, the control group said basically no, it wasn't. But the experimental group, you scored pretty highly best interest. Do you think the hearing aids were worth the trouble? Which I think a lot of people in our field think someone with normal hearing isn't going to want to go through the effort of wearing hearing aids. The people in the experimental group, yes, they found that it was worth their while. For me, the bottom line is, at the end of the 6 weeks, now that the study's over, would you want to continue to wear the hearing aids? Control group, everyone said no. When we asked them why, they said because they didn't help me. So that's good. There was no placebo effect here. But the group in the experimental group, about 60% said yes, they wanted to continue to wear hearing aids because it was helping them in certain situations. And again, this is kind of goes against everything that I think us as a profession think about hearing aids and whether or not they can benefit someone who doesn't have hearing loss and whether they would want to wear them. Well, we decided, okay, so we've now shown that hearing aids can help someone who fits this population. What about some of those emerging technologies? So we looked specifically at AirPods, and we ran the same study. We basically, instead of fitting people with hearing aids, we fit them with AirPods Pro in hearing aid mode. Now we didn't have a control group. We just had an experimental group, but we ran the same protocol, measured them in the laboratory, measured them in the field with 6 weeks of wear. And again, a lot of data. One of the interesting data we used here was the satisfaction with amplification in daily life, which is a validated questionnaire of how people are perceiving benefit of their hearing aids. Now, when this is a scale from 1 to 7, and you can see the questions that are asked here. We modified them so they were asked about the AirPods instead of hearing aids. Now, when this scale was developed 12 years ago, hearing aids at the time were scoring about a 5 on a scale of 7. So you can see a score here of 3.3 is not really very good on this scale. Again, when we asked them at the end of the study, do you want to continue to wear AirPods Pro in situations where you need hearing help? Almost everyone said no. And primarily because either they weren't getting benefit, they weren't comfortable, or there was social stigma around wearing AirPods in a social situation where they needed the help. We had 5 people say yes, they would continue to wear them, but even they said it is embarrassing, and I would only wear them with friends and family where I could explain why I'm wearing AirPods while talking to them, which is not a lot of social situations where people have hearing difficulty where you're able to do that. So can help some, but in a very limited way. So the summary on this part, takeaway that people with this minimal hearing loss, with no hearing loss according to the audiogram, they still have a need for hearing help in some way. And there are some treatments strategies out there for them. We're investigating a variety of different ones. Hearing aids with their speech and noise technology improvements can actually help them. And because they're easy to use, they're small, they're invisible, they don't have a lot of the issues that hearing aids had 20 years ago. And finally, don't rely on the audiogram solely for treatment decisions when someone says that they have hearing difficulty, I think is a takeaway message as well. Then finally, I just want to say, when thinking about innovation, as it's continuing to happen, and I guarantee over the next decade, we're going to see rapid advances in how hearing healthcare is delivered, what is delivered, for whom it's delivered. And it's gonna map across this spectrum from clinical to consumer, across multiple different dimensions. And when we think about what's happening, I find it useful to think about where it falls here. Also, as an innovator, if you're thinking about what is an opportunity, an approach that isn't being done yet, look at some of these mix and matches of these dimensions that have not yet been addressed in the field. And I think that is an opportunity to come up with novel solutions that will fit within our world of hearing healthcare. So that's it. Thanks everyone for your attention, and hopefully you found that useful. I'm happy to take any questions.
Yeah, thanks so much for this. This was wonderful. While questions start rolling in on the Q&A, and for anybody who's attending, please put questions in the Q&A. And if you had a specific question at some point during the talk, and you were asking a question directed to that, if you can rewrite your question so that we know sort of exactly what it is that you're asking here, and we'll work it in at the end. One that I see already is from Dr. Kohlberg. The NAL-NL2 curve provides gain above 6,000 hertz. And this is in reference to when you were discussing the AirPods. Yeah. But a lot of hearing aids do roll off around 4,000 hertz. How did the AirPods specifically compare, I guess in more of an ecologic general sense, to hearing aids when it comes to providing gain past that sort of 4,000 hertz barrier?
Yeah, well, I mean, it is a high fidelity device, so it can provide much higher higher responses. You saw the gain roll off there, I think above 8 kilohertz or so. But what's also beneficial is the low frequencies. Low frequencies tend to get ignored because hearing loss tends to be more high frequency. But because of the open fittings of hearing aids these days, typically there's no gain provided below about 700 hertz, even though some people can benefit from either some amplification or, more importantly, some speech and noise ratio improvements down there. And that's where I think the AirPods can really shine and be superior to traditional hearing aids because of those transducer limitations at the high end, as you point out, but which is a limitation of the receiver, but also the low end, lower frequencies, which is a limitation of the acoustics in the ear canal because of the open fitting of hearing aids and the closed fitting that AirPods give.
Fascinating. I have a question I'll interject. It's super fascinating to think about, when we talk about hidden hearing loss, when we talk about those, who don't fit, traditional peripheral measure criteria. And you sort of mentioned this sort of briefly in talking about the different ways you're thinking about it, but it broadly, where does cognition fit into this? Hearing is a encoding, it's decoding, and the very process that for most of us, we really rank our hearing off of. It's not I can't hear birds anymore. It's not that I'm missing some sound. It's speech, and speech is such a cognitive process. Where do you sort of foresee that going?
Well, yeah. So maybe in a presentation I might have given 15 years ago, I probably spent a whole hour answering that question. I think back 15 years ago or so, we focused quite a bit on the impact of hearing loss on cognitive function and the impact that hearing aid technology can provide to cognitive function. And this is not cognition as I think it's talked about these days in terms of cognitive decline or dementia. I'm talking about acute cognitive ability, such as the fact that because you have hearing loss, your cognitive ability is working in overload. It's more top-down resources are being applied to understanding speech and noise, filling in the gaps, using context to understand what your hearing is keeping from you. And it affects things like memory, attention, fatigue, your ability to do more than one task at a time. And so, I think cognitive, the impact of hearing loss on cognition is incredibly important and separate from the impact on, cognitive health, let's say. And I think cognitive ability also has an effect on your ability to process speech. I think we now know that people who score highly on like reading span tests, working memory tests, do better with speech and noise. We did a study about 5 years ago on hidden hearing loss to try to identify what is a test for someone who has had noise exposure. We found only two things out of 36 different measures. One was the audiogram, your threshold at 12 kilohertz. So even though you had normal hearing up to 8K, if you had abnormal hearing at 12K, that was an indicator of hidden hearing loss. And cognitive ability. So basically your ability to perform on a working memory task was predictive on how you were going to do with speech and noise. So if you measure hidden hearing loss as a dysfunction in speech and noise with a normal audiogram, both of those things were very good predictors of whether you are a high performing person or a low performing person.
Fascinating. I'll ask one last question here before we hit time. It's really, really, innovative what's going on down at AAL. You're thinking about sort of different ways of hearing care in the clinic. You're thinking about who needs hearing care, validating people's needs. How do you go beyond that scope and go sort of outside of our large, hearing networks and our traditional models and get like into the community's head? Is NAL doing anything public facing, whether it's campaign driven or whether it's sort of driving, from the OTC side, like the marketing or anything like that?
Yeah, we are. Again, this is a part of our advice to government. Last year, the Australian government had a national hearing awareness campaign. digital ads, TV ads, and so on. And so we advise them on messaging from a health psychology perspective, how they should talk about it to the common person and not make sort of the common mistakes that someone new to our field does. We also have developed a tool for people who have hearing loss to understand what hearing aid technology does from a user benefit perspective. If you go to any hearing aid website, it's all very confusing. They use marketing terms and the technology is difficult to understand. So we have a tool now to help the consumer, the general citizen, understand what exists out there for the unique needs they have from a user need perspective. So we do a little bit of that, but most of what we do is focused on clinical care.
Well, we are at time, so just being respectful of everyone's time. Dr. Edwards, thank you so much for joining us. This is an extremely interesting topic to go through, and thanks for walking us through sort of these almost like different pillars of innovation in our field, and sort of what it looks like from a research side to analyze them and sort of interpret them through both sort of a clinical lens and also maybe that broader sort of scientific lens.
Well, thanks for the invitation, and thank you for adjusting the timing of this to accommodate my not having to speak at 4 a.m. down here.
No worries. I think it's it's good for everybody.
All right.
All right. Thank you. Thanks, everyone.
Bye.